Hello everyone, I'm Dr. Kajal Pandya and I'm here to discuss the correlation between HbA1c levels and non-alcoholic fatty liver disease severity. Thank you Dr. Amal sir for your guidance and thank you Diakar for giving me this opportunity. So now let's start our discussion. So I'm going to answer 3 questions, simplify. First I'm going to answer why we chose this study, then I'm going to answer how we did it, and then we'll go back to our conclusion, right? So it is a great public health concern. So what is non-alcoholic fatty liver disease? It is a excessive fat accumulation within the liver cells, which is the condition known as steatosis. Now steatosis, is it harmful? Not yet. It is the global prevalence of NFLD has been rising with the ongoing metabolic crisis such as obesity and type 2 DM, right? So steatosis itself is not harmful enough, but the progression of steatosis into steatohepatitis and fibrosis, it can lead to cirrhosis and ultimately hepatocellular carcinoma, which is really harmful. So now we have the known link between type 2 DM and non-alcoholic fatty liver disease. So we can say that if the patient has type 2 DM, patient is at risk of developing non-alcoholic fatty liver disease. And if patient has NFLD, patient is at risk of developing type 2 DM, right? So the premises we are in right now is, if there is metabolic abnormalities always precede the disease. For example, patient was having hyperglycemia before getting diagnosed with diabetes. Patient was having high LDL before actually having episode of MI. So we are filling gap. Basically, the gap is, do you think that only patients diagnosed with diabetes have hyperglycemia? So there are group of population that is having hyperglycemia even if they are not actually diagnosed with diabetes. So the hypothesis we are suggesting is, if pre-diabetes can tell us that the patient is at risk of developing NFLD, and it can also tell us that how severe the disease would be. So we chose this cross-sectional observational study. So cross-sectional study is basically snapshot of the population. It is a concise study. So the key strength is inclusion and exclusion criteria. We included non-diabetic patients post-30 who were diagnosed with NFLD via ultrasonography. So ultrasonography is really smart choice because it is cost-effective, non-invasive and easily accessible. And somehow if we tell patient that एक sonography करावी पड़से, they are very at ease than other investigations. I don't know why. Patients with confounding factors like diabetes, severe anemia, chronic liver disease, and a history of alcohol consumption carefully excluded. Now, confounding factors are the factors that might alter the results of our study. For example, if I want to establish the link between LDL cholesterol levels and MI, so if I consider a smoker patient, then I will exactly not know that if the MI episode was because of LDL level alone or there was a contribution of smoking in it. So those factors are considered confounding factors. Patients with severe anemia was actually excluded because in severe anemia there is very less hemoglobin. So hemoglobin levels are altered. So basically the HbA1c level, we are considering glycated hemoglobin, right? So HbA1c levels can falsely rise. So it can alter our results. So now we have this clear link between HbA1c and non-alcoholic fatty liver disease. What we found from the study was mean HbA1c level of patients was 5.5 or more, and in control it was 5% or less. So the p-value was also 0.001, which suggests that there is 1 in 1000 chances that this finding can be incidental. The risk increases with pre-diabetes. So if individual with HbA1c levels of 5.7% or more showed a 3-fold increased risk of developing non-alcoholic fatty liver disease, and those similar individuals with pre-diabetic range of glycosylated hemoglobins shows 5.5-fold increased risk and chance of developing severe NAFLD. And as we discussed, 10% high average HbA1c was noted in the patients. Now our patient group basically included 75% of grade 1 fatty liver patients, and 25% were grade 2 fatty liver patients. Grade 3 fatty liver patients we unfortunately did not encounter. So HbA1c as NAFLD marker in non-diabetics. Basically, elevated HbA1c tells you subclinical metabolic dysfunction. So there is insulin resistance, and there is somewhat disturbance in hyperglycemia. So it tells you that it is not clinically significant yet, but it is still there. We can also use it as a tool for risk stratification. So this level only does not tell you that patient is at risk of developing the disease. It also tells you how severe the disease might be. And we can also use indices like HbA1c and HDL-C ratio. So HbA1c in that is glucose marker, and HDL-C is basically lipid marker. So we can have brief metabolic dysfunction idea. The potential mechanism for this, I presume, is advanced glycated end product receptor pathways. So HbA1c is advanced glycated end product. So this can initiate inflammatory cascade, and it can lead to fibrosis and cirrhosis. So how this study helps us? So basically we do not perform HbA1c routinely in non-diabetic patients. So now we can use it as an early screening tool for NAFLD. The key takeaway is it identifies individual at risk of developing the disease, and it even tells you that how serious disease might be. The biological link says that it connects glucose dysregulation with liver fat accumulation through insulin resistance. Now, it can also consider as broader indicator because it is also useful in non-diabetic population as well. It tells you early glucose dysregulation and metabolic dysfunction. Now, this new paradigm is we can shift our clinical model from reactive to proactive approach. So, reactive approach is we wait for the symptoms and then we treat the overt disease, and we can shift it to screen for risk and then prevention of the disease. So now actually I found it funny little bit because we are not the person who wait for symptoms to develop. Our patients are. If we tell them to do one more test, then they will tell you that I'm not feeling anything, I'm feeling very good. So they will more or less avoid. Yes. Now we have this limitation. This is cross-sectional nature of study. So we cannot say the cause and effect relationship between high HbA1c and NAFLD. Though there is a strong correlation, the absence of patients with grade 3 limits the generalizability of the study. So we propose longitudinal cohort study for future research. We can also do large multi-center trials, and we can do interventional studies. So basically the idea for interventional study is that if two conditions can share same risk factors, why can't they share the same treatment, right? So we can know it through our interventional studies. So I'll conclude that the study that we done was HbA1c is positively correlated with the presence and severity of NAFLD in non-diabetic population. Elevated HbA1c even below the diabetic threshold can serve as crucial independent risk factor, and it could be valuable non-invasive biomarker for screening and managing NAFLD, which will potentially help us to identify at-risk patient before even developing significant liver damage occurs. These are my references. Thank you.